the DB06 was an excellent sequela of the DB04, because a lot of treating physicians, including myself, were like, do we really need to give one chemotherapy before getting to this very important medication? I mean, it's really improving outcomes. It revolutionized the field. It's a novel way of delivering effective medication to cancer cells and quote unquote ideally spare healthy cells, right? So it's amazing. So why do I have to give a conventional chemotherapy where it hits everything, target and off target equally, hoping to kill cancer more than? So it was really important to move it early on, but the DB06 added a lot more. The DB06 not only looked at that, but it looked at a new entity, the ultra-lows. And ultra-lows were defined with those patients with faint or incomplete staining of less than 10% of the cells. I mean, this is how specific they went. And about 20%, like 1 in 5 patients, belong to this ultra-low category. And it met also its primary endpoint. I mean, it showed great improvement. Again, you see almost 5 months improvement in the median progression-free survival, which is excellent to see. I mean, it went from about like 8 months to 13 months. I mean, it's excellent to see, with also an impressive hazard ratio above about 0.6, also impressive overall response rate in the ultra low as well. So if you look at the HER2-Low, the response rate was about 55-56%, and the ultra low was in the 60% range. So that was amazing to see. But it also opened a lot of questions, because in this day and age we want to be inclusive, right? We want to be inclusive for everybody. We want to try to find more patients that can qualify from important therapies. We don't want to go and try to push away patients from getting those drugs. So if you take in hormone positives, the lows and the ultra lows, put them together, they're 90%. So 90% of hormone positive breast cancer will belong to this category. Only 10% will be labeled as HER2-0. Taking that into account, that there is a study that was published that was at last ASCO, and it was very enlightening for me. They took 512 patients who were HER2-0s, and they found with every biopsy, the chances of converting to a HER2-low was about 35 to 40%. After 4 biopsies, 99.6% of patients eventually had a HER2-low at some point in time. That tells you that those HER2-0, this 1 out of 10 patients that doesn't belong to this HER2-low or HER2-ultra-low, by just doing enough biopsies, they will eventually get it, and they will get a very important drug. So the question here goes, do we really have to check the status? And do we really have to include patients just based on a HER2-low or HER2-ultra-low status? Or we should give it to all comers and then see whether they're not, give the drug a chance. If it works, great.